Thank you very much. I'm very happy to be a part of this group and to be here in the UK. As Terry mentioned, my wife Paula and I spent a few days last week in Ireland. We were in Dublin the day before the Queen got there, so we got to see a lot of security, but we didn't get to see much else because everything was closed. So I'm going to give you some perspectives on metatarsalgia. I'll give you just a quick little background. I am a physical therapist, or physiotherapist as it would be here. My training came out of Indiana University, and then I did a doctoral program through Boston University. And I am in private practice as well. So I will go back on Monday, and on Tuesday, I will start seeing my patients for the whole day. So I'm an 8-hour-a-day practitioner, much as most of you are, and have a lot of clinical tools to work with. I'm probably not as well versed in the research as Jenny is, although I admire the way that she can keep a clinical practice going and still is involved in research and consumes the research. So when I need an answer, I always go to Jenny, and she helped me a little bit when I was going through my doctoral program. And these are the two ladies on vacation from Virginia. That's where I'm from, Virginia Beach, Virginia. And they're being carried up the side of an active volcano. And the one lady says to the other, "Ha, and you thought they wouldn't like Americans. Why, their faces just lit up when I told them we were Virginians." So a little bit different. So I have the daunting task of talking about metatarsalgia, which quite literally means my metatarsals hurt. And that can be so many different things. And speaking, after such very esteemed colleagues as Howard and Jenny and before Trevor, I feel a little bit like Elizabeth Taylor's seventh husband on the honeymoon night. I know what I'm supposed to do, I just hope I can make this interesting. So I'm going to go over a little bit of my perspective. There are a lot of different sources of pain when we talk about metatarsalgia. Certainly the capsule and the synovium are where a lot of these problems come from. That can be joint irritation from instability. It can be joint irritation from abnormal shear and pressure, which I'll talk a lot about. We certainly have problems that come into the bone, and that can be everything from the overuse injury. I see a lot of runners in my practice, so we have a lot of metatarsalgia that we have to be cognizant that it may be a stress fracture, things of that nature as well. And then the plantar fat pad, which when I get into digital deformity, I'll talk about the importance of the fat pad and how that fat pad gets shifted when we have digital deformity, and that as practitioners that needs to be something that we address both through exercise and through supportive things that we do inside the shoe. And then the interdigital nerve, which quite commonly called a neuroma, but a bit of a misnomer in that it's really, it's not a tumor within the nerve, but rather swelling in the epineurium and perineurium of the nerve. So it's actually, if we can get that irritation down, you're not doomed to surgery. Just if you have that interdigital irritation, there are ways that sometimes we can recognize what's causing the shear and actually address that. So I'm going to talk about some of the factors that contribute to the metatarsal pain. And I'm going to focus the most on structural and biomechanical factors. That's where a lot of my practice revolves around, trying to look at the forces and the alignment and the various things that can cause that, and then give you my tools, my little clinical pearls as far as how to address each of these. There are certainly other medical conditions that we have to be concerned about, and I won't be reviewing those as much. I mean, the differential diagnosis for the metatarsal problems, those obviously need to be cleared at times, things where you have avascular necrosis or osteonecrosis and things along those lines. So a good radiograph can be a good help in just ruling those things out. And then footwear, I'll touch on this. You could spend far more than 45 minutes talking about the influence of footwear on foot pain, particularly in the forefoot. And certainly I was saying to someone last night, there's shoes for fashion and shoes for function. And it's always hard to get the patient who's having pain in their foot to realize that maybe you're going to have to spend a little bit more time in a healing shoe and a little time out of the fashionable shoe and find a balance there. Again, there's some emotional attachment to the type of footwear that I'm not always able to overcome, but I certainly will go that direction as well. So my first thing I'd like to talk about is the influence, and this actually dovetails very nicely with what Howard was saying in his presentation about what can happen at the talocrural joint with an ankle sprain. And that may be the source of some of these problems with the ankle joint dorsiflexion. As Howard mentioned, when we walk, as we take a step, the tibia has to translate 10 degrees forward of vertical over the talus in that closed kinetic chain motion. And if there's any restriction, that has to be compensated for somewhere. So this is a very common thing in clinical practice. And as Howard mentioned, it can happen as a result of a simple ankle sprain. When we sprain our ankle, that anterior talofibular ligament is anchored to the fibula. So when we sprain the ankle and go into that inversion adduction motion, that can drag the fibula inferiorly and can drag it forward. And so that may cause a block, a physical block to their ability to translate smoothly as far as the tibia and the fibula moving over that. And the same thing can happen with immobilization, where people are in some type of a boot and they're not really moving the ankle, and that talus drifts a bit forward. And then when they try to get their dorsiflexion, they get an impingement. So it can be problems of the joint, and it can also be problems within the Achilles tendon. One thing that we're making you do for hours right now is sit. And that can be the root of all evil. And I see a lot of, in my own practice, there's 3 muscle groups that are chronically a problem, because the more, and particularly in the use of technology, the more we use technology, the more we sit. And so those muscle groups would be the front of the hip flexors being very, very tight, the muscles in the back of the thigh, and the muscles in the back of the leg. So the tendo-Achilles is a very common source of problems, both in terms of metatarsalgia, but a myriad of other problems, including the intolerance of a foot orthotic device. Because as we'll mention when we get to the compensations, one very nice place to compensate for a tight Achilles is the middle of your foot, in the mid-tarsal region. And that's where a lot of people get their motion. Now the mid-tarsal region can have its own equinus. If we look at the foot from the outside, you can see the plane of the heel and then the plane of the forefoot. And on that foot, you can see that it's dropped down. It's plantar flexed. And that's a plantar flexion at the mid-tarsal joint. Now, in noting that, those come in 2 varieties. We have a very flexible type, which sort of self-reduces. This is the more flexible cavus foot that has a forefoot equinus. It will load prematurely, but it has the ability to self-reduce. The more problematic one would be the one where when instead of, when they're in this downward position and we try to reverse that and take them into dorsiflexion with some abduction, which is the oblique mid-tarsal joint axis, it's restricted. There's a tightness. Another way to often see this is in weight bearing. If someone has this forefoot equinus and they're in stance and you're looking at them from a lateral view, if you can still see that shadow of the lateral arch, that's typically one of your more hypomobile or rigid forefoot equinuses, where the forefoot is now causing an increased demand on the talocrural joint. So that will, again, be another source of premature loading in the forefoot. Now, another test that I do in my office for ankle joint dorsiflexion, really tests the joint very well, is to have someone go into a full squat in standing, go down into a full squat with the heels down, and then come back up. Now, if they can do that, then they obviously have good excursion, good range. If when they go down, they either can't go all the way down, and of course the knee can be the issue here too, but if they can go down fine with the knee as long as the heels are up, but they can't do it with their heels down, then that may indicate that we have a problem with the ankle joint. Another little tweak of the test is to simply put a block underneath the heels and then have them try to do the maneuver again. And if they used to have a problem, couldn't do the squat, and now they can do the squat, then we know that talocrural joint's a problem and probably needs some mobilization. So again, this is the ideal. This is what we'd like to see. Someone who can do the squat with the heels down. So that's a functional test. Now, when people have an equinus influence, that tends to load all the metatarsals excessively. So the callus pattern for this may be diffuse callus across all the metatarsals. Now, it can also exacerbate one of the other foot types that I'll go over. For example, someone who has a very late pronatory motion in the foot often has a very unstable first ray, which results in a transfer load to the second metatarsal. If you mix that with a talocrural equinus, it's going to magnify the effect of that late instability, because you have both the loading from the first ray instability as well as the equinus influence on top of it. But given no other structural problems, diffuse callus kind of across all the forefoot is a classical equinus callus pattern and can be very much related to the metatarsal pain. Now, in terms of treatment, I do a lot of manual therapy corrections, much like Howard does, in terms of trying to get some motion back in the joint. And we would do those typically to get the motion actually from the talocrural joint itself. And some common faults that I see, I mentioned the fibula being in an inferior position. So the correction for that would be a superior glide of the fibula to get it back and clearing. And then restricted inferior tibiofibular joint. As Howard mentioned, the high ankle sprain, that syndesmotic joint that we have at the distal end of the limb, that can become quite restricted, and we can increase mobility there. A gliding of the tibia, as Howard mentioned, it's not really so much ankle joint dorsiflexion this way that we need to think of. It's more the tibial movement. So a gliding of the tibia, and if that can't glide over the talar trochlea, that can be something that we work on as well. Or thinking about it in reverse, and now gliding the tibia posteriorly and medially. So this is what some of those things would look like. So this is patient inside lying. I have my right hand, the thenar eminence, sort of hooked under the fibula. This hand is right up at the neck of the fibula superiorly. And I do a superior glide. And one of the other things, actually more from a New Zealander, Brian Mulligan, does a lot of mobilizations with movement, where there's a lot of movement superimposed. So the movement that I'll use here is with my fingertips here. We're trying to glide the fibula superiorly while at the same time assisting the patient in getting those perineals working and to actually produce an eversion movement of the ankle. The inferior tibiofibular glide, what we'll do here, because the ankle joint axis, when we're born, our ankle joint axis faces straight ahead. In the neonate, the tibia and fibula face essentially on the frontal plane. As we mature, that rotates outward. So when we're doing a mobilization, we actually want to either move ourselves so that we're moving in the plane of the ankle, or if they have adequate rotation of the proximal limb, we can simply internally rotate their thigh and now put the ankle joint straight ahead. Now when we're applying our posterior glide, that is going to go in the normal direction of the ankle joint itself. So either rotate the patient or rotate ourselves. And again, trying to get that into a more posterior position is often a very helpful thing to do. For the anterior tibial glide, there's a couple different ways that I do this. One would be I put the towel here to try to get the ankle joint out of extreme plantar flexion. Best position for me to do my mobilizations would be about 20 degrees of plantar flexion. And then stabilizing here at the anterior talus, right at the neck, and then just applying an anterior glide through the tibia. Now, if that's working well, and then we see some good things happening as far as their movements, maybe their squat ability is getting a little bit better, I might become a little more aggressive, and we'll use a gait belt or a mobilization belt. And so again, I'm positioning myself so that I'm slightly lateral to their limb, so that I'm in the axis, the plane of the axis, and then I apply a force by simply leaning backward through the belt. And then as I maintain that anterior tibial glide, you'll notice that now the individual comes forward, and as the person comes forward, now the tibia should glide over the talus better with less impingement of the anterior talus. So as they're coming forward, you'll notice also that I dropped down. So you'll see that I've dropped a little bit lower, and that's so that I can maintain the angle of the belt perpendicular to the tibia here, maintain an effective force that way. And many times that pinch that they felt in the front of their ankle goes away after they've done this a few times. Now the other thing that we can mobilize is the talus itself. So now instead of moving the tibia anteriorly and laterally, we're going to glide the talus posteriorly and medially. And again, I'm happy to show these in the breakout sessions as well. But again, positioning them on a roll, internally rotating the limb, putting a thumb on either side of the extensor digitorum longus tendon so that we're right on the anterior margin of the talus, and then applying a glide, and then checking to see how has that affected their ankle joint dorsiflexion range. Now the one thing that I have noticed with this, and Howard also showed some different ones that may be helpful in this case, is if people have a chronic anterior tibiotalar impingement. They have this loss of dorsiflexion, but they've created a little bit of synovitis, or in some cases even an osteophyte in the front of the ankle. This may not be the most comfortable thing to do. You may want to go with more of a tibial glide in that situation, or something that's a little less direct on the anterior talus, because that anterior talus, in fact, might be quite sore. Now, the other thing that I mentioned outside the joint is that we may have a problem with the tendo-Achilles, tightness in the Achilles tendon that's causing premature loading of the metatarsals. So if this is the case, the problem is when we tell a patient to go stretch your heel cord, most patients are already a little bit toed out. That's the normal angle of gait, externally rotated a few degrees. So when they go to a wall and they lean forward, their center of mass is going to fall to the medial side of the foot. So it's basically going to bring them into further pronation of the subtalar joint. And that, of course, allows their midtarsal joint to be even looser. So instead of translating at the ankle, they move the axis of rotation down to the middle of the foot. And so that's something that we don't really want to have happen, because that can lead to a lot of other problems. It can be a big problem in some of the issues that we deal with our patients having plantar pain, plantar heel pain. So there are ways to get around that, but they typically would involve teaching them to stretch, excuse me, teaching them to stretch in a more supinated posture of their subtalar joint. So my recommendation is to try doing it this way. So rather than stand toed out, we're going to have them stand with their feet pointing more internally rotated. So the feet straight ahead to slightly internally rotated. Now, at the same time, we're going to have them lift their arches, shift their weight to the outside of their feet. What we're really saying is supinate your subtalar joint. Now, as they do that, they'll typically use the anterior tib will be one of the muscles that they will use to sort of come out of this pronatory posture. So you point that out. Point out the tendon. And if they can, maintain that anterior tibialis contraction while they then lean forward. Now, I'm not a big fan of leaning forward with the hands, because people have a tendency to kind of do it this way. So I typically will have them do more forearms to the wall, so that that actually brings the hips forward. And if you think back to what Howard said about the reciprocal inhibition that we get, the biceps and the triceps analogy that you used, that actually factors in here too. When they fire that anterior tib, as they're doing that forward lean, we get two good things. One is it helps to maintain that supinated posture of the rear foot. The second thing is the reciprocal inhibition. It should also inhibit their tight gastroc, which is sort of fighting that. So this is sort of the way it would look. So here they are, again, slightly internally rotated, lifting the arches, producing an anterior tib contraction. Then leaning forward, you can see again, more arms on the wall as opposed to hands on the wall. Now, some people don't quite have the motor skills to do that. Can't really maintain a good posture. It might be a child. So there are other ways to maintain that posture. You can use a foam wedge or a rolled towel underneath the medial side of the foot and accomplish the same thing. The key is to try to make sure we're getting the motion from where we really want to get it from and not compensating through the mid-tarsal joint. Now, there are many other ways that people can do this. That you can do this with something that was actually created sort of by a car mechanic. It's actually a set of drum brake pads. He was a car mechanic trying to stretch out his Achilles, and he found that if he stood on these, he got a nice stretch to his Achilles. The reason has to do with what toe dorsiflexion does to arch stability in first ray position. That when your toes go up, the rays go down and become much more stable. So the fact that this was a little more than a semicircle actually helped to stabilize the midfoot, made it harder to cheat in the arch area. So that's sort of one of the reasons why the Pro Stretch works. Now you'll find in splint manufacturing, they'll often do the same thing. They'll include a little wedge that can be placed under the hallux for the same reason, that when the person is using that low load stretch at night, a little bit of dorsiflexion to the toes can also stabilize and prevent unwanted mid-tarsal motion. Now I do the same thing. I'll often sometimes put a little bit of a medial wedge inside their night splint if they're going to use one, and that will again keep them in a little bit more supinated position. We don't simply want to pull the toes to the nose. We'll have to think about where is the motion coming from. Is it coming from the ankle, or is it coming actually from the midfoot? So this is, again, this can be your helper, or this can be the source of all evil. This is the windlass mechanism, which, again, Dr. Dannenberg's done a tremendous amount of work on this, and I use it every day in my clinical practice as far as my techniques. I'm trying to promote a good first ray position. You can see as the toe goes up, what happens to the position of the first metatarsal. So that's really what we're trying to do with a lot of these techniques. Now, in terms of other biomechanical treatment, I do use heel lifts for equinus influences, particularly if they're recalcitrant. If I know that we have a bony problem that does not respond to manual therapy, maybe we have osteophytes present, maybe this is an ankle joint that's not going to get all of its motion, or maybe we have the equinus influence and it's on a truly structurally short leg. Well, if that's the case, we may be able to kill two birds with one stone by putting the heel lift on the short side, and at the same time that may unload those metatarsals on that same side. Now, I use an incremental approach. I typically don't start with as much as I think that I may need. I'll stop at the point where the patient's symptoms are well controlled. The heeled shoe sometimes is going to be a very helpful thing in the treatment of equinus influence. And then there also are the shoes that have a very aggressive rocker bottom. And some of the reasons why people like those is because of the prevalence of the equinus influence. People's metatarsals do feel better when they're wearing a Skechers Shape-Up or an MBT because they're simply rolling through and not getting the motion. Now, unfortunately, those people also get up in the middle of the night to go to the bathroom. And so that's going to be the problem. When they're barefoot, they're going to have a lot of problems. If you rely completely on your shoe, you're going to have to wear that shoe pretty much all of your waking hours. So I like for the patients, if at all possible, to resolve that equinus influence other ways. Now, there also are structural problems within the forefoot that can create issues. So this would be an example of the forefoot varus. So there's our heel alignment. Now we look at the forefoot alignment, very inverted forefoot alignment. So as this goes through the gait cycle, that forefoot has to get to the ground. So this would typically be someone who goes through a late pronatory compensation. And with that comes first ray instability and a lot of excessive gliding and shear because of the loss in stability to the midfoot. So this is sort of what's going to happen when a forefoot varus comes to the ground. This is a right foot, heel strike, foot flat, mid stance, heel off, toe off swing, coming to the ground, hitting on the lateral side of the heel. Rear foot is compensated. Forefoot has its varus. So the normal amount of pronation will not be enough. They're going to have to go a little further to get that forefoot to the ground. Now they come to heel off. So through mid stance, they're pronating farther. Now they come to heel off. Unfortunately, the thing they're compensating for is still on the ground. So this requires excessive and late pronation even after the heel has come off the ground. So this can be a source of tremendous first ray instability. It can be a source of excessive gliding and shearing in the lesser digits. Now the callus pattern, when that happens, because the first ray is not stabilized with the loss in stability with the pronated subtalar joint and the mid-tarsal joint becoming quite loose, the second metatarsal ends up taking a lot of the load. So a lot of pain, shear callus under the second, also the third and fourth metatarsals is a very common pattern. In terms of treatment for this, if in fact I saw that in their structural alignment they had a forefoot varus, a very simple forefoot post, and I like the ability to kind of change out, try it a little bit there. The Vasyli, we have 2 and 4 and 6 degree forefoot varus posts. So I can try different amounts to see how much relief they're getting. Or if I think that we have a very high forefoot varus, I might start at the lower end and then over a period of weeks gradually wean them to a higher level of control as we go. Now the other thing that I am a big fan of is the ability to mold the midfoot in this area with the heat gun to get better support to the mid-tarsal joint. Because there are people who, it's more than their structure, it's actually their ligamentous laxity. These are the folks that may not have a lot of excessive subtalar pronation when they stand from their neutral to their relaxed position. We don't see a lot of excessive subtalar motion, but we see a lot of arch collapse. And it was a bit of a confounding thing for me early in my biomechanical career because I would see the large amount of arch collapse and assume that that was all because of excessive subtalar pronation. And so I would be wanting to correct the subtalar joint and correct their structure when in fact some of that was just simply ligamentous laxity. And because we're using a device that has a little bit more flexibility, we can mold that nicely to the contours of the midfoot, and that gives us more of a static support to those ligamentous structures around the mid-tarsal joint. Now, this might be, when this midfoot support will be comfortable as long as they have adequate talocrural dorsiflexion. One of the most common reasons for orthotic failure, this is the patient who says, the arch feels too high. Or when I wear these, my heels pop out of my shoes. Or when I wear them, I feel it in the back of my heel. I feel it in the back of my knee. That's someone who's often compensating with mid-tarsal motion, excessive arch collapse, because of their tight heel cord. And many times they'll come back, maybe I've made them a foot orthotic, and it was comfortable. And they come back and say, I don't understand. It's been 6 weeks. I think the orthotic's broken. I say, well, what are you feeling? Well, the arch feels too high. And so what I'll do is I'll take the orthotic devices and check their ankle joint dorsiflexion, see that they clearly have not been continuing to do their stretching. And I say, okay, we're going to do a little modification here. I'm going to go back into my office. While I'm doing that, remember those stretches that we went over when you were here? Well, I'd like you to go ahead and go through them. And I'm just going to have my aide watch you, and I'm going to go modify your orthotics. Then I go back in my office and I read the sports page for about 10 minutes. And then you come out, say, okay, let's try these now. And they put them in the shoes and I was like, oh, that's so much better. Well, then you have the discussion of, I actually didn't change your orthotic devices. But that's how important those stretching exercises that we went over when I issued you the orthoses is just as important as the orthotic device itself. So we have to be a little bit careful with this midfoot support because they'll tolerate that, but they won't tolerate it if they have talar crural tightness. Now we also have a forefoot varus that looks like a forefoot varus, but doesn't function in the compensated fashion. This would often be someone who lacks range of motion back in the subtalar joint. So instead of seeing callus and pain on the second metatarsal, they have callus and pain on the fourth and fifth metatarsals, on the lateral side of the foot, which doesn't seem to make sense because you would think the forefoot varus wants to pronate. And as long as they can, they will. But some people don't have the range of motion to do that, so they end up staying with much more of a lateral load. So again, this person would be an underpronator with high excessive loads on the lateral side. Now, in this case, I typically don't use a biomechanical approach with posting. I use more of a softer accommodative approach because, again, we have a range of motion restriction. So I try to get them to a more neutral shoe with no pronation control features because, that shifts them more to the outside of their foot. I'll use one of the softer devices, a shock absorber. Actually, the Armstrong device, though I know it was created for the diabetic foot, I use it a lot for the hypomobile foot, too. The tighter foot that needs a little bit of shock attenuation, they just need to be on a good program of replacement because the material will wear out so that their tissues do not. And so I just have to make sure they understand this is not a device you're going to keep for 3 or 4 years. You know, we want, as soon as the device is worn out, then we're going to replace it with something else. So we do want a foot orthosis, but not so much the biomechanical or motion control device, something a little bit more soft and accommodative. Now, I will still often balance the forefoot, but I'll use the softer materials. Actually, I often use the pour-on plugs that come with the Dannenberg device. After you've done a bunch of Vasyli orthotic devices, you have a whole drawer full of those. And so I'll often use those to create a medial forefoot bias so that it brings the ground up, but in a very non-aggressive way. So that if they did tend to get motion into it, it would allow the motion to occur. Now we also see the opposite. We see the higher arched foot, more of the valgus forefoot. And these come in 2 varieties too. The flexible that actually sort of self-reduces, and the non-flexible or rigid where this is going to drive the rear foot into some bad positions. Now quite commonly, this comes with a plantar flexed first ray. So the mobility and position of the first ray becomes a very important thing here. Their medial forefoot will load right after heel strike. They will typically load the medial forefoot because most of these feet also have a forefoot equinus. So that's going to bring their forefoot into play that much sooner. That will bring their first ray into play that much sooner. So that's going to lead to compensatory supination. If the first ray doesn't dorsiflex out of the way, it can throw the subtalar joint to a more supinated position and create high loads both on the first ray, but also with the supination comes a locking of the mid-tarsal joint, creating a much more rigid foot. So not only is the medial column stable and rigid, but the lateral column is locked down as well. So we see callus typically on the first and on the fifth. So this is an example of what it would look going through the gait cycle. They hit on the lateral heel, almost immediately, prematurely loading the first metatarsal. Now the soft forefoot valgus would simply move through that. And that can now be another problem because that first ray may be unstable. But the one that's a little more hypomobile may be thrust back the other direction. And this can actually be another factor behind some of the things Howard talked about with ankle sprains. This person is dangerously close to an ankle sprain. So this hypomobile forefoot valgus can be something that often causes peroneus longus tendinitis and recurrent ankle sprains. So they're getting a high load to the lateral side now, and this is kind of what that would look like on the graph. So they hit the first metatarsal, and that thrusts them back towards a supinatory compensation. So again, first metatarsal pain, sesamoiditis. You know, the people who come in, they've got a lot of pain on the first metatarsal. Also sometimes a mirror pain or callus on the fifth metatarsal. And in terms of balancing that, there are a few different ways that we can do that. We may be able to just simply put a lift or a post on the lateral aspect of the forefoot and bring them into more symmetrical loading. The other way to do it is to actually create a place for that plantar flex first ray to live. So you can mix the two. And I'll often do that. And in fact, I'll often use a Dannenberg, which has a lot of ability to modify first ray positions by creating a little well for the first ray with a lateral post so that we can now balance that forefoot and prevent them from going into a premature supination. Now, because many of them also have an ankle equinus and or a forefoot equinus, it's very common for me to also add a lift to the back of the device, just a neutral lift to bring their forefoot and rear foot into more sequential loading so that they're loading heel and forefoot more at the same time. Now, we also can see the dorsiflex first ray. Now, if you think of the windlass mechanism and how that might present, if a plantar flex first ray gives me a lot of hallux dorsiflexion, the dorsiflex first ray does the opposite. And that's where the hallux limitus, and particularly, it can be structural or functional, but if we have a dorsiflex first ray, that's going to be the person who often presents with a loss of hallux dorsiflexion. So if it's above the plane of the lesser digits, as you see in this lower picture, that would be our dorsiflex position. It's actually not just dorsiflexed, it is a triplane motion, so it's really dorsiflexed and inverted. And when we get to the manual therapy, the correction is simply to move that in the opposite direction. So it's typically caused by poor stabilization against ground reaction forces. This may be the late effect of a compensated forefoot varus, or the late effect of an unstable first ray. It causes a lot of excessive load to the second metatarsal for the same reason that the compensated forefoot varus did. In fact, their callus, their pain pattern may be very similar to the forefoot varus. The difference might be this callus that we see over on 5. Why the callus on 2 and 5? Well, the callus on 2, because the first ray is unstable. So the second metatarsal is left holding the bag. But then as their first ray tries to come over this dorsiflexed first ray position, they can't get the first ray forward, so you have to shift, and they create a lateral weight shift off to the 5th metatarsal. So if they end up with a structural or functional hallux limitus, that may be the effect you see here. So a callus on 2 and 5 may well indicate sort of this dorsiflex first ray position. Now, in terms of treating it, there's a couple different ways. I would certainly do the manual therapy correction would be to try to bring this first ray into a more plantar flexed and everted position. Sort of the same way your hand moves. If you put your hand out like this, and you kind of move your 1st and 5th ray, you can see that they kind of move in that direction. That's the same direction of the first ray within the foot itself. So it's plantar flexion with some eversion. And the muscle that can help reintegrate that motion is the peroneus longus. That is one of its functions. It's not just a mover at the ankle, it is also a mover of the first ray, and it's a dynamic stabilizer of the first ray position. So as we get a little better position, I'll do again more mobilization with movement, having them sort of integrate some peroneus longus contractions with that. Then after we get a little bit better motion at the first ray, then I will go ahead and try to work a little bit more on hallux motion as well, and integrate both of those together. Now, in the orthotic device itself, I'll often do a Morton's extension, or the opposite of a first ray cutout. It's actually a first ray platform. Modification that I would do to it is I sand down or taper the end of it so that you actually have a little bit of a rocker underneath the first ray. So they have a platform for their dorsiflex first ray, but they also have a taper to it to create the same thing that this shoe does. See how it's sort of swept up there? That creates a little bit easier transfer of weight forward over the metatarsals. And again, the shoe itself may be a very helpful thing. If you take a shoe and you push down on the toe box, you can see how much of a metatarsal rocker you have by how high the heel comes up. So these are people that have a dorsiflex first ray with a loss of hallux motion. That can be a very, very helpful thing as far as their efficient transfer of weight forward over their forefoot to this little metatarsal shape. So that's the rocker effect on the device, and then this would be on the shoe itself. Digital deformity would be another thing that can be a source of significant metatarsal pain. So when the toes get clawed up or hammered, as we get the toes go up into dorsiflexion, if you remember back the windlass mechanism, the rays are driven down. The other thing that happens is that the plantar fat pad is pulled forward away from the metatarsals. And so some of my elderly patients feel like they're walking on rocks because of their metatarsal heads are so prominent. And part of that is because their toes are drawn up this way, and the fat pad that should be cushioning and protecting has been pulled forward, and so now it exposes their metatarsal heads. So in terms of treating that, there's a couple ways to go about it. One would be to actually try to see if we can get better plantar flexion of the digits. So we can do individual mobilization or manipulation of the actual digits themselves to try to promote a little bit more plantar flexions. For the plantar flexion, we typically go in a plantar direction. And then passive stretching. If they have enough hip mobility, we would show them how to do some self-stretching of the toe extensors. The other way to work on this is to offload the metatarsals with a metatarsal raise. The Vasyli green metatarsal raise is it's a nice size. It's not over-aggressive. I've used others before in that. Now, the other way that you can do this is to create the donut principle, sort of pad around the painful metatarsal. And again, I often will steal my little Dannenberg pads for this as well. So we find the offending metatarsal, and then I will just put pads to each side of that, trying to respect, if I can, what is the normal contour of the metatarsals, meaning that the first ray is longer than the fifth, so it typically doesn't go straight across, but I'll do a little bit of cutting and curving so that we're respecting the normal shape of the foot anatomy. Then with regards to the metatarsal raise, there are some common problems I see as far as where people put the raise. A lot of people actually are putting it far too close to the metatarsal heads themselves. The metatarsal arch is actually at the level of the cuneiforms. This is a foot in the anatomy lab, and I'm holding it. This is a right foot, and you're looking at it from the rear. This is the navicular bone that I've pulled down so that you can see the three cuneiforms. And they actually look just like that Roman arch. You know, that middle cuneiform is just like the keystone of an arch. So this is actually where the level of the metatarsal arch is. It's actually at the bases of the metatarsals. The heads should all essentially come to the ground. So putting a pad underneath the metatarsal heads really doesn't make as much sense as putting it a bit more proximally. And there was also some studies done actually at Washington University in the USA where they looked at the optimal positioning for a metatarsal raise to decrease metatarsal head pressures, and they found that if you put the edge of the metatarsal pad just proximal to the metatarsal heads themselves, that's the best place to reduce the pressure. If you went a little too proximal, you didn't get the offloading. If you went too distal, you impaired metatarsophalangeal dorsiflexion. So the proper place for this would be just behind where the metatarsals hit. So on the device itself, this is sort of where we want it, right behind the metatarsals on a 3/4 length. That's sort of the correct length for the device anyway. So it has that nice convenient lip where it'll sort of hang over and give you that extra support to the metatarsals. If we use this on a full-length device, I will often sand down the edge of the device so it sits down a little bit more flush on top of the device. But again, trying to respect where do the metatarsals hit and then placing that pad just proximal to it. Now, not all problems are from problems within the foot. I had a patient who came to me, an elderly lady, and she was sent to me by her physician. He wanted me to evaluate her for foot orthotic devices and whether I thought that they would be appropriate for her. And it was a bit confounding because she had what looked to be an extremely compensated forefoot varus. She had a forefoot varus foot type. When she stood statically, she had severe pronation, collapse of the arch. The problem was where her pain was. She had fourth and fifth metatarsal pain, fourth and fifth metatarsalgia of the fourth and fifth rays. And normally, for treating a compensated forefoot varus, I would post the medial side of the foot so that she wouldn't compensate. Well, that didn't make logical sense to me because her pain was on the outside of her foot. So I said, okay, I've done my static evaluation. I need you to take a little walk for me. And so she did. And as she walked away, I began to see the problem. So I said, have you had problems with that right hip? Oh, yes, I had surgery on my right hip. Did you? Let's see how you are standing on one leg. And of course she couldn't. She couldn't balance her pelvis because she had no hip abductor strength. And if you ever try that, try walking with a compensated Trendelenburg, where you shift your weight to that foot. Your weight goes completely to the lateral column. Now, I could have spent the rest of the day trying to fix that with an orthotic, but it wasn't what the lady needed. She really needed me to address some of those proximal things. So I'll briefly discuss how some of these proximal factors also have to be considered when we're dealing with metatarsal pain. So a few things: a wide base of gait, narrow base of gait, toe out, and toe in. So a wide base of gait. Where can this come from? Well, when you have a genu valgus or you have obesity and the feet are farther apart, the center of mass is going to fall medial to the foot, and that can accentuate your pronatory motion. And again, that's going to cause more medial loads to the forefoot and can mimic a forefoot varus or can exacerbate a forefoot varus. Now, the causes would include tight iliotibial bands. If the iliotibial bands are tighter, it makes it tougher to produce a normal base of gait. If you have genu valgum, and that can have components of both structural and functional because of weakness in the hips. Obesity, if we have much larger thigh mass, you can't get the feet close together, which makes for more medial load to the forefoot. And then postural instability, the ataxic patient, the patient who has a little bit of difficulty with balance, they will typically ambulate with a wider base just because that's more posturally stable. Now, in terms of treating this, for stretching the iliotibial band, I like to use a wall stretch, actually several different stretches, but with a wall stretch, the common mistake is that people do a trunk lean, and it's not so much of a trunk lean as much as it is a glide of their hip while maintaining that hip relatively level towards the wall. And then I'll do self-stretching with them in different positions of hip flexion and extension. The tensor fascia lata, which is really the muscle of the iliotibial tract, has two functionally distinct parts to it. EMG-wise, the anteromedial portion fires with your hip flexor, and so it would have to be stretched with the hip and extension. The posterolateral fibers of the TFL fire with the hip extensors, so much more at heel strike and typically going to be stretched in more of a flexed position. So when we're stretching the iliotibial band, I'll typically do both of those things. Now, certainly working on body weight is a lifelong problem for many people. Try to be kind with that, because one of the ways we try to maintain appropriate weight is to stay on our feet and stay active. But the more they see that happen, the more you'll see a reduction in the width of the base of gait. And then postural stabilization exercises, which can be anything from just simply standing in a doorway on one foot to using devices like this that create more of a perturbation or more of an upset the apple cart in terms of your postural stability. Now, we can also have the opposite. We can have a very narrow base of gait. You can see this. I see this in a lot of what we would call soccer, you would call football, but a large amount of tibial varum. And you can see with that case, the center of mass may now actually fall to the outside of the subtalar joint. And so that can now produce high lateral loads. Now, causes for that could include a short leg. You may be supinating the short side as a compensation. It could be hip abductor weakness. I mentioned the gal that I was treating that had the 4th and 5th metatarsal pain. And a big genu varum or tibial varum. In terms of treating that, equalizing leg length, you'll hear me talk a lot more this afternoon on leg length, so I'll save that discussion for later. Strengthening the hip abductors, this is a nice way to start, but a bad way to finish. If you just want to show them where they are, this is a good way to do it. But your hip abductors in real life don't have to do this too much. Most of the time what they're doing is trying to hold your pelvis stable. So as Jenny said, we much favor the closed kinetic chain exercise once someone has a base of strength to work with. That is a little bit challenging for people that are already very, very weak. So sometimes I won't do things like this that are a little bit farther down the road. This is actually a good stabilization exercise because you're trying to hold the pelvis in a stable position, but we have to be a little bit careful about their upper extremity, make sure that we don't create high loads there. And then we have the toe in, toe out. So if we have a toe out influence, that could be anything from tight hip external rotators, femoral retroversion, external malar torsion. All of those things create an increased toe out. If you put your hand on your table and you put your hand a little bit more toed out and now bring your weight forward over that hand, you'll find that kind of late into the period, you'll find your weight coming medially towards your thumb side, and that may be what is happening with their toe out gait. So this can be another source of metatarsal troubles. If they have an increased toe out gait, that can cause the same effect of late pronation that is caused by something like a forefoot varus. Or, if you have a forefoot varus, this can magnify its effect. Now, some of these things we can work with. Tight hip external rotators, I can. If you have external malar torsion, that's a bony alignment thing. I'm just simply going to have to recognize that as a source of trouble. So in terms of physiotherapy things that I might do for this, we can do external rotator stretching, trying to promote a more internally rotated position, internally rotated gait. We can also do internal rotator strengthening. So what she's doing here is kind of stabilizing here, holding there and resisting as the patient is pushing with their hip internal rotators. And our final one here is excessive lateral loads caused by a toe-in gait. Now, toe-in would be just all of the opposite. So we could have tight hip internal rotators, femoral anteversion, internal malleolar torsion, or the most common in my practice is weak hip external rotators. And I think Jenny would echo that that's a very, very common thing that we see in clinical practice. And that tends to decrease the angle of gait. And then if you think of your hand on the table, as we progress our weight forward over the foot, that's going to bring more excessive lateral loads into the metatarsals. So if there's a way for us to more normalize the angle of gait through stretching or strengthening, that would be something I would pursue. And so these are some examples of stretching as well as strengthening of the external rotators. These are called clamshell exercises. And we'll do these both non-weight bearing, but also weight bearing. We call them monster walks. We'll have them put the band around their knees and they'll produce that externally rotated hip position, and then we'll have them sort of do some walking to kind of keep those glutes firing. I'm sure you'll hear Jenny talk more about glutes this the weekend because I've heard her a few times, and that's part of why I stress the importance as much as I do. Footwear, the common issues I see as far as causes of metatarsal pain are just the narrow toe box, excessive heel height causing that same load that an equinus ankle does, a lack of proper contour. Many fashion shoes are not designed around the shape of a human foot, but rather around a fashion ideal. So when people are putting their foot into that shoe, we produce a lot of metatarsal pain. And then the materials. Again, typically the fashion shoe made of much more rigid materials. Although there are options out there that look fashionable that still are a little bit more functional. So in summary, metatarsalgia it's a multifactorial problem. The problems can be both in the foot and outside the foot. It can include both the proximal factors as well as those distal factors. And there are a wide variety of approaches to treating this, from exercise to modifying an orthotic device, to posting the orthotic device. But it really takes a good comprehensive look at what are all those different factors that they bring to the game in terms of what their causes of their metatarsalgia. And that would be it.